Hello again, everybody. We're going to talk about congenital neck masses here, and because these are congenital neck masses, these have a tendency to present in children. So we're going to talk about these first three here, the thyroglossal duct cyst, the branchial cleft cyst, and the cystic hygroma. These three are more common than these last two, and so I bold-faced these here because I really want you to be aware of these. These last two are pretty rare, but the first three are likely to come up on the test. And what's really going to help you differentiate these is the location, where these cysts, where these anomalies are. So the thyroglossal duct cyst is a fibrous cyst, and it forms because of a persistent thyroglossal duct. What is the thyroglossal duct? The thyroglossal duct is an embryologic structure, and it connects the point where the thyroid forms, which is posterior to the tongue, and it proceeds all the way down to where the thyroid comes to rest, which is in its anatomic position in the lower neck. So if you travel that space from the posterior tongue to the thyroid where it's in the neck, there's this duct that connects the 2 points. And normally, the thyroglossal duct involutes. And so you don't have this duct anymore. And the only remnant that you have is this little, I'd call it a depression on the back of the tongue, on the posterior tongue, called the foramen cecum. However, in patients with a persistent thyroglossal duct, this duct can still be open. And so because of the persistence of the thyroglossal duct, you can have an ability of oral secretions and mucus secretions to accumulate down into that duct, and that eventually will form a cyst, because the only place, the place where the thyroglossal duct ends is thyroid tissue. So there's resistance there. And so all of those oral secretions will form a cyst, and it'll be in the neck, in the thyroglossal duct, which is persistent because normally that involutes and is no longer. So the symptoms of a thyroglossal duct cyst is a midline neck mass. So remember that the thyroid is a midline structure, and this is a duct that connects the back of the tongue where the thyroid formed to where the thyroid is, which is in the middle of the neck. So this is a midline neck mass. It's roughly in the region of the hyoid bone, and it tends to be painless. However, if the cyst becomes infected, which it easily can, if bacteria get into the cyst and colonize, then it can be painful, and you can see even some erythema over the cyst. Otherwise, it's smooth and cystic in appearance. It tends to be around 1 to 2 centimeters in diameter. And what's important to remember, in addition to the point that it's midline, is that it moves upward when the patient protrudes their tongue. So if you have the kids stick their tongue out at you, the cyst is going to invariably move upwards. And that makes sense because this duct is starting at the posterior tongue and is going down to the cyst and to the thyroid. So if you move your tongue, the cyst is going to move with it. So as I mentioned, the cyst can become infected, in which case it can be painful. You can get erythema, cellulitis over the duct. If the cyst is large enough, then it can interfere with breathing and swallowing. And most thyroglossal duct cysts are diagnosed in patients under 20 years of age. However, it's been my experience that the majority of patients are quite young, school-age children. So here's a thyroglossal duct cyst. And I would say the differential diagnosis here would be, number one, would be a goiter. So you look at this and think, oh, maybe this is a goiter, and you would get thyroid function tests. And that would certainly be on your differential for labs to get. So for diagnosis, the best initial diagnostic step is imaging when you suspect a thyroglossal duct cyst. And since most patients who present with the thyroglossal duct cyst are young, the best initial step is sonography, because we don't want to expose them to the radiation that CT would put them in. But if the patient is an adult and they're presenting with a suspicious thyroglossal duct cyst, a CT is more reasonable, just because when you have an adult, when you're exposing them to the radiation, it's less likely to cause cancer, and also because in an adult, we're also thinking of possible malignancies. Routine labs certainly are warranted in your workup, and definitely include thyroid function tests because you want to rule out any other problems surrounding the thyroids. The treatment for the thyroglossal duct cyst is surgical excision. You'll remove the entire duct, and this procedure is called a cyst trunk procedure. So what you're doing is you're removing the cyst and any sinus that exists all the way to the base of the tongue. You're removing any fistulas if they're present, and you're also removing the middle third of the hyoid bone. And about 65 to 70% of thyroglossal duct cysts will be below the hyoid bone. 20% are above the hyoid bone, and the rest of them will be at the hyoid bone. If the patient has an infected thyroglossal duct cyst, if it's infected, then you want to provide the patient with antibiotics until their fever goes down, and then you can do the surgery. Surgery is contraindicated during acute infection. So here's sonography of the thyroglossal duct cyst, and you know the hypoechoic nature of the cyst. Usually there's a little bit of material you might be able to see in the cyst, but it's generally hypoechoic in relation to the surrounding tissue. Look in here. Usually about 1 to 2 centimeters. Here's another one. It looks like there's some erythema over here, so perhaps this is an infected thyroglossal duct cyst. Okay, the branchial cleft cyst, usually when you hear it referred to just the general branchial cleft cyst, what they're actually referring to is the second branchial cleft cyst. Yes, you can get branchial cleft cysts from other branchial arches, but the most common one, almost 90% of them, are caused from a failure of the second and third branchial arches to fuse. And so this results in a remnant cyst, and it's an epithelial-lined cyst. And like I said, about 90% of them are a failure of the second and third branchial arches to fuse, and that's the second branchial cleft cyst. So if you hear branchial cleft cyst, usually they're referring to the second branchial cleft cyst. All branchial cleft anomalies, regardless of which ones they are, will be along the sternocleidomastoid and the anterior triangle. And if you remember back to the trauma surgery section where we talked about the neck, the anterior triangle is pretty much your clavicle, your trachea, and the anterior ligament of your sternocleidomastoid. So it's that triangle that's formed there. And so most of the branchial cleft anomalies will be in that anterior triangle close to the sternocleidomastoid. Typically, the branchial cleft cyst is found in the superior part of the anterior triangle, and a lot of times it's considered in the preauricular position. So if you look at the sternocleidomastoid, it goes all the way up to the mastoid process, and that's right up next to the ear. And so a lot of times you see the cyst, it's actually right up, just posterior, or right up in front, anterior to the ear. So around the ear, preauricular, within that anterior triangle. So the symptoms here are a lateral neck mass. So unlike the previous cyst that we talked about, in this case, we have a lateral neck mass. So this is not midline. Usually this is also asymptomatic. It can also grow and shrink with the coming and going of various infections, especially upper respiratory tract infections. Rarely it can become large enough to cause dysphagia and respiratory issues. For diagnosis, the best initial test is sonography, although CT can be considered if the sonogram is undiagnostic or if the patient is an adult. So again, here is a perfect example of that preauricular positioning of the branchial cleft cyst. So this is a lateral neck mass. Here's another one. This was a little bit further down, but you can see it's not in the midline position like the thyroglossal duct cyst. The treatment again here is surgical excision. This can be complicated, however, due to the fact that around the branchial cleft cyst typically are the very vital structures such as the jugular vein and the division of the carotid artery. And so it's useful to have a CT with contrast preoperatively so you know around which structures you're going to be operating on. And surgery, again, is contraindicated during an acute infection. You want to resolve the infection before you approach the patient surgically. A cystic hygroma is a congenital deformity of the lymphatic tissue of the neck. It results in a multiloculated benign lesion which varies in size. Essentially, what we have here is lymphoid tissue that is not competent, and the lymph that drains into these lymphatic vessels will become absorbed by the tissue around it, and so you get this, you get lymphedema, I would dare to say, in the neck, because your lymphatic system is not conducting properly here. And so this results in a multiloculated, of course, benign lesion, which can vary in size depending on the amount of lymph that's being drained. This originates in the posterior triangle. And so when we're thinking about posterior triangle, we're thinking about the posterior border of the sternocleidomastoid and the trapezius muscle. And so this is a little bit further back than the other ones. In some cases, if it's large enough, it can extend into the region of the anterior triangle, and if it's large enough, it can cross the midline. So it really depends on the size, but at the smallest, it'll be in the posterior triangle. A lot of times you can diagnose this antenatally via ultrasound if it's large enough. The symptoms will be, as you can imagine, facial and neck distortion, difficulty feeding, respiratory distress, and brachial plexus compression. If you transilluminate the lesion, it will transilluminate because these lesions are full of lymph fluid. And during infection, because the lymphatic circulation increases, these can increase in size. A sudden increase in size poses the risk of hemorrhage, and that can be fatal. There's an association between cystic hygroma and Turner's syndrome. So for diagnosis, although they can appear clinically obvious, imaging is really important for reassurance and surgical planning. So the best initial diagnostic test is going to be an MRI. And you want to get an MRI versus a CT or sonography here because it provides optimal soft tissue detail. This is a soft tissue problem. And you should get it with contrast because this can differentiate the cystic hygroma from a hemangioma, which is another kind of growth that you can get on the neck, which is also congenital. The treatment is partial surgical resection. It's very difficult, if not impossible, to remove the entire cystic hygroma. And what we also use then is sclerosing agents, and that scleroses the tissue that forms the hygroma, and ultimately the goal is to sclerose off all that lymphatic tissue so that you no longer get this collection of lymph. And we have better and better sclerosing agents coming out. So right now, I think what they're using for the most part is doxycycline. They use bleomycin. They use pure alcohol. They also use a detergent. All of these are given locally, but these all have side effects. So there's a new one called OK432, which is still in trials, but this has been shown to be much superior to the ones that we're using now. On an obstetrics note, if a cystic hygroma is presumed antenatally from sonography, remember you can diagnose this via sonogram in a pregnant woman, the mother should be advised to deliver in a facility that has a neonatal intensive care unit, and she should definitely be delivered by an obstetrician. Reason is because obstetricians, if they need to do a cesarean section, they can. And if the baby is difficult to deliver vaginally, they know some of the maneuvers that can be done to help facilitate the vaginal delivery. The baby should then be transferred to the NICU for observation, especially for airway monitoring, and then referred to pediatric surgery for definitive treatment. So here's an example of why you may need to do a cesarean section on a cystic hygroma baby. Ultimately, you do surgery, you remove a lot of that tissue, use sclerosing agents, and these will shrink down. So again here, lateral neck masses, but they're from the time of birth. And they'll transilluminate if you flash a light underneath it. Okay, so beware of a test question that presents you with a patient of a history of cystic hygroma at birth. They may tell you, depending on the age of the patient, that it's a baby with lymphedema of the hands and feet and coarctation of the aorta in addition to cystic hygroma. It may be a school-age girl with a history of cystic hygroma, and she has short stature, low-set ears, learning difficulty in math but not in reading, and a so-called webbed neck. Or it could be a 16-year-old girl with a history of cystic hygroma who hasn't yet menstruated or developed secondary sex characteristics. And what would you have here? You would have Turner syndrome. All of these would be consistent with Turner syndrome. And when you have babies, girl babies with cystic hygroma, you should get a karyotype to check for Turner syndrome. Turner syndrome is an anomaly where the baby girl, who's visually, macroscopically, phenotypically a female, actually only has one X chromosome as opposed to two. So this is sort of like your female equivalent of Klinefelter syndrome. The thymic cyst is a remnant of the thymus in the neck, and it follows its embryologic descent into the mediastinum. 95% are unilateral. Unlike a thymoma, which is a tumor of the thymus, a thymic cyst is not associated with myasthenia gravis. Benign and malignant hyperplasia have been noted, and that's why it's indicated that these be removed. Symptoms include a neck mass in the anterior triangle. Usually it's asymptomatic, but it can cause dysphagia if it grows large enough. The thymic cyst tends to present more inferiorly than the branchial cleft cyst does. The branchial cleft cyst tends to be up closer to the ear. Because these thymic cysts are so unusual, CT should be obtained to definitively rule out other possibilities, including thymoma. And the treatment is surgical excision. And you'll want to do a biopsy on that as well to see if there's any malignant transformation. Parathyroid cysts are incredibly rare. I think there's only been about a few hundred cases described in the US. It's paratracheal in position. It can be on either side, left or right, but it's around the trachea, and it's just inferior to the thyroid. Typically, it presents in patients around 30 to 50 years of age, and it usually comes up as a quote-unquote thyroid nodule just because it's in that position and it's a mass around the thyroid. But all thyroid tests should come back unremarkable because this is not a problem of the thyroid. Symptom-wise, it's asymptomatic. However, if it's large enough, it can cause hoarseness and respiratory destruction as well as tracheal deviation, but this is a minority of cases. And in another minority of cases, the parathyroid cyst can secrete parathyroid hormone. This is what's called a functioning cyst. And in that case, the patient should have labs and signs consistent with hypercalcemia. Remember that parathyroid hormone increases your absorption of calcium. So these patients should have high calcium levels and signs that go along with that. The treatment here, again, is surgical excision. So just to recap, the thyroglossal duct cyst is located on the midline. Typically, it's diagnosed in school-age kids. It's firm and non-tender, specifically elevates with tongue protrusion, and it should be excised. The branchial cleft cyst is in the anterior triangle. It tends to be preauricular in front of the ear. Usually you see this also in school-age kids. It's also firm and non-tender, and this should be surgically excised. The cystic hygroma is in the posterior triangle, but can easily be larger than that. It can extend into the anterior triangle past the midline. Usually this is diagnosed antenatally or in infants. On physical exam, you'll note a diffuse neck mass. You may also note other features of Turner syndrome. You should at least get a karyotype. The treatment is a partial excision, sclerotherapy to reduce the size further, and a karyotype to diagnose Turner's if it's present. And you only need to get the karyotype if it's a female baby. The thymic cyst is in the inferior anterior triangle, down closer to the clavicle. A typical age where it's diagnosed is in adults. Physical exam will reveal a firm non-tender mass. The treatment is surgical excision. And the parathyroid cyst is paratracheal in position, typically presents in middle-aged adults. It's also firm and non-tender, and surgical excision is the treatment of choice.